Thank you so much for having me, and thank you everyone for coming. And I also want to give a nod to the person who helped to design these slides, Kay Crapel, who is on the call today, and to all of our incredible Amigos team. And I know I see some of our representatives from our partners network on the call. So glad that everyone is here. So I want to talk a little bit about applying health literacy to the COVID response and what that means, and really focus a little bit, just a wee bit here too, on what health literacy skills might we be taking away from. Um, I am, the learning objectives went out, but just as a reminder, after attending today's presentation, participants should be able to define health literacy, at least somewhat, describe healthcare professionals' role in health literacy, describe the relationship between health literacy and healthcare quality, and describe the impact of low health literacy on the mitigation of COVID-19. And finally, demonstrate the ability to use plain language to explain some different facets and concepts of COVID-19. So we'll be moving through today. I think we decided that we were going to hold questions till the end, but I might be asking you some questions, and we might have some back and forth as we move through today's session. So roughly dividing it into five different areas, talking about health literacy really as the national crisis it is. And COVID is one of the things that showed us just how big a crisis it is. Then we want to talk about the complexities of defining health literacy and sort of what some of the current thinking of the definition of health literacy is. Then looking at the clinician's role in health literacy, what are 6 concrete things that I'm hoping that if you are in an active setting where you're working with patients, you can take 6 actual concrete things away from today's session that you could change your practice this afternoon with. Finally, I want to talk a little bit about, I've alluded to the issues around health literacy in the COVID-19 response, but just talk a little more about how how low health literacy complicates our response. And then we'll conclude with a sample of some of the work that we're doing in Doña Ana County with the Salud y Vida con Amigos program, working to address health literacy in COVID-19. And please, if for some reason I'm not speaking loud enough or I'm going too fast or anything like that, please just let Mario know and he'll flag me down here, okay? So health literacy is a national crisis. This is from Richard Carmona, who was the former U.S. Surgeon General. He said this in 2008, and things have not gotten better, they've gotten worse. The poor state of health literacy in America is a crisis. It is an underlying cause of disparities. It is also a source of extensive disempowerment and perpetuates preventable disease. We cannot work and say that we're working on health equity unless we're working on health literacy. Without health literacy, we do not move forward. And it is not only an issue for those who are somehow other, who are underserved, or who are, have low education. It's a bigger issue, but I will pause just briefly to let you know a little bit of what drove me to this work, which is my own mother's story. She had a master's degree in speech pathology. She knew so much about medicine and health. Her mother had colon cancer at age 40. At age 75, my mother was diagnosed with colon cancer. Her body was riddled with tumors. So many, they didn't even count them on the scans anymore. If there were a stage 15 cancer diagnosis, she would have had it. It was colon cancer. She had had 1 colonoscopy. She died 2 years later after a tremendous fight. We knew she wasn't going to survive, but we did get 2 years with her, most of which were reasonable quality. But it was preventable. And it was a gap in health literacy on her part and on her provider's part, who did not recognize that this very proud upper middle class white woman with the best insurance in the world, the one we never worry about, would be too proud to ever let her doctor know that she was having abdominal troubles with gas and other things like that. That's health literacy. Health literacy is a two-way street. And it is one of the reasons I am driven to do this work. In a health literate society, everyone has the information they need to be healthy. Everyone can find, understand, evaluate, and act on health information to achieve better health. You'll note that I'm using 4 legs to this table. We always add evaluate to some of the definitions that I'm going to show you now. And we'll talk more about why that's so important. Healthy People 2030 has updated its definition of health literacy. Since 2010, health literacy has been a foundational objective in the Healthy People 2010 goals and objectives for the nation. In 2030, they adjusted their definition to make it read the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. There are 2 important things about this definition. First of all, they shifted to the concept of use. It's not only finding and understanding information, but they have to be able to use it and apply it. And secondly, it's informing health-related decisions, not assuming that we know what the appropriate decision is for that person. The second important thing, or I guess third important thing that the Healthy People Task Force did, is they added the concept of organizational health literacy to its definition of health literacy, recognizing that organizations actually also need to be health literate. And that's how much we enable people to actually be able to do those things that find, understand, and use. So at the organizational level, they play an important role. So it's important to see that that's shifting as we move forward. In the Amigos program and in a lot of the work that I'm doing, and I think COVID again has brought this out, there's a third type of health literacy that encompasses the personal and the organizational, and that's community health literacy. This derives from work done by the University of Maryland's Center for Health Literacy, the Horowitz Center. But community health literacy says that health literacy doesn't happen in a vacuum. It doesn't happen just when we say we're going to go give health information. It happens at all levels, all the time, across institutions in a community. The institution starting with family and neighborhoods. And it's a reflection of a culture. It's a reflection of all of those critical information needs. Health professionals are still critically important, but they're not the only source. So the map kind of looks like this, that people are getting health information from all of these places, including those communication channels like social media. And sometimes that can be problematic. But when we build community health literacy, we have a base that we can help to fight misinformation and other things with. And more people know. We share day in, day out. Moms share in the park after school how they take care of their kids. And it happens across the board. So ending with a definition of health literacy, and I think this is the definition that probably encompasses all of it. It's a shared responsibility between patients, anybody who's receiving health communications, and providers or anyone who's giving health communication. The responsibilities that we communicate in ways that the other can understand. So, and I'll follow that up by George Bernard Shaw's famous saying that the biggest risk of communication is thinking that it has happened. And so often we do that in healthcare and in our public health work, no matter where we are. If we don't know that we think it's happened and it hasn't. So I'm going to pause to ask you something and go ahead and put your answers in the chat. What percent of the population is considered to be a proficient level of health literacy? We'll just take 30 seconds for some chatting, or as people, I can move on as people put those in. What percent? 82, 36, 20, or 12 are proficient? Okay. The impact of health literacy. I told you my own personal story, but it's repeated over and over again. Health literacy allows people to translate health information into appropriate health decisions. Low health literacy levels lead to less use of preventive measures and care, inappropriate use of healthcare services. How many times have we screamed about why did you bring your kid with a snotty nose to the emergency department on Sunday morning, right? Increased less ability to manage chronic or long-term illness. The person with diabetes who seems to constantly be calling the ambulance because they've cratered again because of a DKA. Negative psychological effects, shame, being afraid to ask questions, and overall poorer health outcomes. And poorer health outcomes mean less healthy communities, less productivity, fewer workers. We're not doing our work here. Health literacy, as I said at the beginning, is a health equity issue. And here's your answer. Only 12%, slightly over 1 out of 10 of adults in the US are proficient in health literacy, that they can navigate most of what they need. And you know what? If you're an oncologist and you're talking to an orthopedist, you might not be having a health literate conversation. So it's not just about training. It really is that communication again. Low health literacy is often associated with some negative social drivers of health. Low education and socioeconomic indicators do put people at greater risk for low health literacy, which again puts them at risk for more health issues. So we don't know how much of the disparities that we see in health are really driven by low health literacy. When people just don't have time to learn these things. And it may be a critical mediator reflective of the social drivers that impact health disparities. Maybe it's not that disparity itself, maybe it's not a driver as much as it's that mediator. So if you're in a situation where you're negatively impacted by things like lack of housing, lack of education, poverty, all the things that we talk about I use the word drivers instead of determinants, right? We talk about that all the time, but low health literacy is going to mediate it in either a negative way or higher health literacy can actually help us to get out of that negative piece. And I know Ned is on the call, and he's been doing tremendous work with health literacy for adult basic education learners. And so that's a place where we can really do incredible work. And I should say Dr. Rubin is on the call. Apologies, Ned. So what's the clinician's role in health literacy? Again, I'm quoting from another former U.S. Surgeon General, Regina M. Benjamin. As clinicians, what we say does not matter unless our patients are able to understand the information we give them well enough to use it to make good healthcare decisions. Otherwise, we didn't reach them, and that is the same as if we didn't treat them. So literally, you may be speaking Latin to your patients unless they understand you. And this is a little bit difficult often for clinicians because, and this I'm going to again pull out of my experience as an explanatory health journalist. When you're in medical school, you use and learn a certain discourse, certain language to describe concepts. When you're then asked to describe those concepts, everybody, I do it all the time with my 15-year-old, Mama, what does that mean? Right? And I'm like, well, I know what it means, but how do I define it to you? Right? Because you learned it in a certain kind of discursive way. So that word has so much nuance and language and meaning to you, but how do you convey that to someone else? And so it's a two-way street, again, that often in medical school and in medical training period, it becomes a big thing to learn the big words, right? And that's how the concepts are taught, is with those big words. So how then do we learn how to convey it to someone else? We really learn it when we are able to. So here are the 6 steps that I think can make a difference to anyone. Create a welcoming environment. Assess your patients or clients. If you're a CHW, I saw a couple doulas here. Health literacy level. Reduce the complexity of forms that you're asking them to fill out. Speak and write in plain language and use teachback. And finally, assess the written materials for health literacy before distribution. I often refer to the Salud y Vida con Amigos program as the No More Fire Starter program, because we don't want to be just setting out stuff that people aren't going to use. So let's look at each one of these 6 steps in a little more detail. Creating a welcoming environment. Remember, shame often goes with low literacy. If you can't read, if you're not very adaptive, you can't understand, it can be shameful. So create that environment that's shame-free. I'm here to help you. Aesthetically pleasing. And here I am always grateful to Kay for reminding me over and over and over again. Aesthetics make comfort. They make people feel valued. Make sure that there's beauty in the care that you provide. It should be comfortable at every stage of the medical encounter, from calling to make an appointment to dealing with the financial stuff. That person should feel comfortable, welcomed, and helped. Culturally appropriate. And always offer assistance with language, filling out forms, and other things that surround the health care. That's the welcome, and do it in a way that makes people feel like it's very normal. It's what we do. And provide resources when necessary. Behaviors. When you're having an encounter or when you're looking at a patient's behaviors, you want to know what dance you're going to do with that patient. Are you going to do a fancy tango, a slow waltz, or are you just going to dance really slowly and teach them the footsteps, right? And that's the health literacy dance. Their behaviors can give you a clue. Yeah, you can do a formal assessment, but who's going to sit down and have your patient do the short assessment of health literacy at every clinical encounter? No. Instead, we're going to look at behaviors. So are their forms incomplete or inaccurate? Do they miss a lot of appointments? Do they have difficulty taking their medications correctly? Are they not completing those referrals you're giving them for laboratory tests or imaging or other referrals? It might just not be that they're non-compliant, right? We use that label, non-compliant patients. It might not be that. It might be that they don't understand what you're asking of them or why it's so important. So take the time to check. Other indicators, how do they interact with the written information? You give them something to read, they say, oh, I forgot my glasses. I'll read this when I get home. That's a famous one, right? I forgot my glasses. Could you read this to me? Might be an indicator of low literacy. Let me bring this home so I can discuss it with my children. Or the reading the paper upside down. Or watching their eyes aren't tracking across the page if you give them something to read. So you know that we're dealing with low literacy here. Medications. I'm going to keep going because I know we need time. Sometimes people may be unable to name their medications. I can't tell you how many times as an EMT, I would go into somebody's house, get given a bag of stuff. Well, and that's my little blue pill, and that's my water pill, and that's my, right? They can't name their meds. They don't know what they are. They don't know their dosages. They can't explain the purpose. or the timing of the administration, or note that they're asking for refills too frequently or infrequently. One of the things that triggered off my diagnosis of dementia for my father was I went up and realized he hadn't been taking any of his meds, although he claimed he had. Or you prescribe a med and the lab tests aren't changing like you would have expected them. Instead of just increasing the dose, check to make sure that there's understanding of how they're supposed to be taking those meds. Forms. Anybody like filling out medical forms? I get confused. I have a PhD in English and I get confused by these forms, right? Okay. Um, so if you're using forms in your practice, take some time to review some forms using a formal assessment tool. There are a lot of them out there. The quick checklist is a great down and dirty way to do it quickly. Suitability of assessment is the granddaddy of all assessment tools. We have, as we'll talk about later, a full course on assessing written materials. So there are formal ways that you can evaluate them, and that's one of the things I always encourage. Eyeball stuff, look at jargon and complexity, just reduce it. Make the language active, not passive. See what words are in there that might be difficult for understand. And finally, assign staff. Community health workers are just amazing. I can't say enough when we work with community health workers all the time to assist people with filling out forms. They can also help to address the cultural barriers. You may have somebody in your office who can do that. So reduce the complexity and the barriers to getting those forms filled out. You'll get better information on your end, and they will be able to give you more stuff. Speak and write in plain language. Easier said than done, right? Just avoid those jargon and medical terms, right? It's not easy to do. It takes practice. It takes a lifetime of practice. It's why I have a job as an explanatory health journalist anytime I wanted, right? Explain those medical concepts that people may not be familiar with. Use visual aids. Often words aren't enough. You need to use those visual aids, models, pictures, videos, and make sure the instructions are explicit and include things that you might not know. And only offer that need to know information, limit it to 3 to 5 key points because it's too much for people to take in. So all we can do in plain language is better. Let's take a little break. Oops, I'm not quite at that slide yet. So of course, listening carefully without interrupting. When the patient uses words to describe their health or illness, reflect those words back. Don't come back in with a diagnostic term. Use their words. And of course, always be sensitive to culture, customs, and beliefs. And yes, we must always think about that in terms of ethnic background and other cultures. But as I pointed out with my mother, the culture, customs, and beliefs of an upper middle class white woman are also culture, customs, and beliefs. So we need to be aware of all of those things. Let's take a break, or not a little break. I want some people to take a stab at a couple of words. We won't do all of these just because I know we'd be here for the rest of the time just doing this. But who wants to give me a plain language definition of ambulatory? Word we use all the time, right? What does it mean? So you're trying to explain to a patient what ambulatory means.
I'll take a stab.
Go for it. Yes.
It means you're able to move around. You can walk around. You can on your own with your own power, essentially.
Perfect. Thank you. Yes. Okay, somebody else for virus. What's a virus? Come on, we've been talking about COVID, nothing but COVID for 4 years, right, folks? Anybody ever explained what a virus is to a patient?
I try to, but I usually then defer to you. And I'm from a medical family.
If I go very, yeah, this is every time I see a list like this, I'm like, oh, I know that, and then I don't. But explaining it in a way that is more of a descriptor, so saying this is something that makes you sick, and then describing some of the elements that may happen to the person. Maybe even using the word, well, that could also make it infectious. I don't know. Because that can then be mistaken for an infection that then someone can have a completely different way of thinking about it. But yeah,
it's tough.
It is.
Right. And I mean, it's a piece of genetic material, sometimes how I land on it, but the effector, a germ that makes you sick and that can get in your body and make you sick is really kind of what people need to know, right? But at the same time, they also need to understand, and this is how we get people back for the booster shots, right, for the vaccine, that it mutates really quickly. It's a piece of genetic material that's in there changing all the time, right? So these are really complicated things. And I wanted to bring this up because these are words that we're using all the time when we're talking about COVID, right? All of these things. Quarantine. What's the difference between quarantine and isolation? A mutation and a variant. Airborne versus droplet. What's a fomite? All of these words are words that people are reading, they're seeing in the media, they're seeing all over the place, and they're really, really hard to understand and they're not getting defined well. And in order to make decisions about, do I need to go get that booster vaccine that was just approved by the CDC last week? They need to understand that a virus is something that mutates a lot. And now we've got new variants that are immune, that we don't have immunity against. And our T cells have been damaged by it. And that mRNA is different from DNA. And that's all around that decision of, do I go get the jab? Right? We're asking an awful lot of people these days. And of healthcare communicators. Okay, another poll. Studies have shown that what percent of the medical information patients are told during office visits is forgotten immediately, and nearly what amount of the information retained is incorrect? Go ahead and put your answers in the chat. Give about 30 seconds in. Okay, so the correct answer is C. 40 to 80% is forgotten immediately. Like they walk out and it is gone. And nearly half of the information that they do retain is incorrect. I saw some 80 to 100% from people who've been clinicians for a while. So, no, but 40 to 80 and half. And that's that statistic is from the AHRQ, the Agency for Healthcare Research and Quality. So that's a big problem. So how do we handle that? Fortunately, there's a tool that can help to increase that retention. And that's called TeachBack. Anybody heard of TeachBack before? I mean, we do it in elementary school classrooms. We can also do it in clinical and public health settings. When we use TeachBack, we simply are asking patients to state in their own words what they need to know or to do about their health. So for instance, after working with person with diabetes, you might say something like, we covered a lot today, and I want to make sure that I explain things clearly. Let's review what we discussed. Can you please describe the 3 things you agreed to do to help you control your diabetes? So this is where we're putting it back in the patient's lap and asking them, can you explain back to me what I just explained to you? The second piece is not only describing, but actually showing that skill or concept. Things like taking a medication. I've noticed that many people have trouble remembering how to take their blood thinner. Can you show me how you're going to take it? So asking them to actually demonstrate a skill. How are you going to do those glucose tests? How are you going to do the things that you need to do that we just discussed? So that gives you confidence that that person can do it. In some practices, this is actually performed by a health coach who leaves, because we know clinicians have 15 minutes max, but that can work. Some rules of thumb, and we have a whole course again on using teachback, so this is like the most semi-condensed thing I can do. Number 1, remember, you're assessing yourself, not the patient. It's not a test of the patient's ability to comprehend. It's a test of how well you explained. Chunk and check, especially if there are multiple things you're going through. Stop at different points during the visit and make sure that the person's understanding is appropriate. That we're doing it right now in this session, right? We're stopping and looking and asking questions so that we can kind of review the materials. Chunk and check. Use show me. Again, ask patients to demonstrate skills like taking a medication, performing a glucose test, or everybody's favorite, correctly wearing a face mask. Supplement teach back with handouts. You can write down important actions. Make sure that these handouts, which we'll talk about which ones you're using shortly, are health literate, and circle or point out the key information that customize those handouts in before you give it to them. And finally, assess those written materials. The biggest thing is make sure your materials fit your audience's needs. I know somebody who was passing out materials from CHOP, wonderful materials, but to really low literacy parents. And they were going, I don't know what to do with this, because they're dense pages of material. So we need to make sure that there's a good fit. So use a validated tool. Again, we can talk more about that in different settings. It's a whole course unto itself. But the point I want to make here is that there are validated evidence-based tools for assessing health literacy of materials, and learn how to use them. And audience testing, no matter what we think about it, until we get it out there, use that material in the real world with the real audience that we're trying. We're not going to know whether it really works for them. Always remember, as Dr. William Osler told us, the good physician treats the disease. The great physician treats the patient who has the disease. Another view of health literacy, it is comprised of so many different things from both the communicator and the communicatee's perspective. We all need to build all of these skills. Yes, general literacy is super important. It's at the center of the circle, as we can see right here. But so many other things also play. There's graph literacy, science literacy, visual literacy, numeracy, data literacy, digital literacy, but also some key skills like relationship building, critical thinking, and communication skills. All of that is part of health literacy. So now, as promised, to everybody's favorite topic, health literacy and COVID-19. Health literacy has impacted our response at individual, organizational, and even policymakers levels. Policymakers have made bad decisions because of their own low health literacy. They've been swayed by voices that are not evidence-based and science-based to make some decisions that have been harmful. And so it is a society-wide problem. It's not just it's not just the farm worker who you're trying to work with, it's across the board. Situational awareness, we were told, know your risk. If you're not health literate, how in the world are you going to know your risk? I don't know my risk walking around any day anymore. We don't even know what the spread is. It's going to impact people's willingness to engage in preventive measures like masking and distancing. Acceptance of vaccines, only 17% received the last booster. Who's going to receive this one? Especially with the bumpy rollout, we've got to do better. And recognition of misinformation and disinformation, which is huge. Infodemic. We are in an infodemic. That's why this critical ability to assess your materials, evaluate them, has become more and more important. The World Health Organization defines an infodemic as too much information, including false or misleading information in digital and physical environments during a disease outbreak. This morning on the Hill, I ran into somebody who, well, I don't really know her, but her dogs are friendly. So we've said hello a few times. And she informed me that Bill Gates started the World Health Organization. It's a project of Bill Gates, the World Health Organization. Dr. Tedros would probably be really impressed to know that. But the infodemic is wild. It's really, really overwhelming. Good information coming through is overwhelming. As you know, there are literally more than 1 million papers have been published on COVID at this time. Some are still preprints, but there's more than 1 million, and nobody can keep up with all of that. And things keep changing, so we really are in an overwhelm. And again, pointing out the vocabulary that we're asking people, it's head spinning. Endemic, pandemic, epidemic. People can get away with calling it endemic because nobody knows what endemic really means. And then the epidemiologists go and jump up and down and shout, but they're not enough to overcome the policymakers that are calling it endemic. So low health literacy, high health literacy challenges. Anybody want to help me read this graph? What do we have on the y-axis?
The estimated daily infections.
Yep. Estimated daily infection. This is based on wastewater data. So it's probably a little more reliable than we can get from testing data at this point, right? And along the bottom, what's on our x-axis? I don't know.
Dates.
You can see. Dates, right? So from the beginning of the time, end of February, when we started collecting the data, up until 9/16/23, just a couple days ago. Anything stand out to you about this?
Yeah, it looks like it's starting to go down.
From
this. This is Anne. When you showed this to me yesterday, I almost had a little stroke because draw a straight line from here, from the 16th of September. It is equal roughly to, I'd say, February 14th, 2020. That's not really very good.
Now we are at a level right now, approximately 1 in 50 people in the United States has COVID. And so we are at a level that's higher than about 70% of the pandemic. But it takes skills to read that, right? We need to know, oh, let's follow this line. Let's look here. All of the red is where we're at high transmission. Our lowest ever was actually here, not here. Right? So is it over, folks?
I think it's just beginning.
But my point is, these are the kinds of things that we're being asked to read to interpret the situation right now. What about this one? Anybody make any sense of that?
I need a drink. This is whoever wrote this map or graph or whatever it is must have been sleep deprived. It's absolutely undecipherable to me.
So the message of this one is that there are many, many different mutations happening. We always have a variant swarm. It's all, and this is convergent evolution just in the XBB. Remember, we're way down that evolutionary chain, but we see a lot of the same mutations happening from multiple different routes, which is concerning. And all of those mutations give more transmissibility and more virulence for this thing. So, but understanding these things, how do we translate this into things that people can make? And this is where Salud y Vida con Amigos comes in. The mission of Amigos is to make sure everyone has the information they need to be healthy. We help people find, understand, evaluate, and act. Anybody heard that one before? On health information to protect themselves and their loved ones from COVID-19 and other health threats. So that's the mission of the program. We work in Northern Doña County with expansion happening now to other areas, including statewide, we're hoping. So with incredible work. So we do a few things: develop and distribute easy to understand health education materials about COVID-19, train community health workers and other community leaders how to communicate about it so they can share with community members, train healthcare professionals in best practices communication, and hold trainings both online and in person when safe. I should caveat. Everyone, we've got multiple different audiences. Neighbors are our community members, people in the community. Champions are community leaders and community health workers, people who are willing to take a role in our community literacy model. Those people who work in the library and work in the schools, who are willing to learn accurate information and learn how to convey it. Guides are our clinical staff, healthcare professionals of any ilk, public health professionals as well, whose job it is to do communication and can participate. And finally, our partner organizations are different organizations that are committed to being part of our road of the institutions in the community that are committed to organizational health literacy and building health literacy. Some of the program activities include COVID literacy courses, Health Literacy 101 for champions and guides, and community outreach. The COVID literacy courses, and I'll show you a little sample from our first one, Breathe Easy. But these are some of the topics that we're addressing. Breathe Easy, the mighty mask, explaining how masks work instead of just fighting about them. Pregnancy and COVID, vax to the max. When COVID comes home, switch cheese, and finally, talking with your doctor about COVID. Was especially important for people with long COVID who often are dismissed or symptoms may not be recognized by physicians. And consider this a sales pitch for Health Literacy 101 for champions and guides. And I'm going to click these in quickly, sorry, okay. But about health literacy, it's basically a whole course divided into two parts with different lessons. The first focus is on some of the context, some of the things we've been talking about today, only a little more detail, the impact of health literacy on our society and on us individually, and then some hands-on tools and skills in developing better communications. And so I also wanted to do a little example of our community outreach. Here are a couple of flyers. Again, huge kudos to Kay, who just is always bopping me on the head saying, Renee. Nobody can read that. So English and Spanish, multiple translations, really working hard on language and visuals to know that visuals are really an important part of how we communicate. So this is a general flyer and then one from our Remembering Forward mural program. Poll question. COVID-19 spreads in what way from most to least common? Give me an answer in the chat. All right, somebody spill the beans. Ann, Kay, Ned. Who's going to spill the beans? Answer is
D.
D, aerosol, or D, aerosols, droplets, and fomites, right? And think about as aerosols, 90% or more, droplets, yeah, maybe a couple cases, fomites, hardly ever, no proven cases on fomites, honestly. So, what are fomites, everyone? Speaking of plain language?
Stuff that's on the surface.
No, it's the surface that's contaminated.
The
It's a
surface.
contaminated
Okay.
surface, right? And so it's the handle, it's the door handle that somebody's, so very, very rarely, but almost always the spread is aerosol. But it's a really complicated topic. There's been huge fights between the engineers and the IAQ experts and the WHO. I mean, even the WHO and CDC still says mostly droplets, right? But it's aerosol. And so if you look at the papers put out by the engineers, it brings me back to sitting down with my dad and his grading his engineering students' graduate exams. It's very complex. We see equations like this one. So how do we communicate clearly about a complex topic? I'm no air quality expert. It's outside of our disciplines. And there's a whole different discourse, just as we use a different discourse in medicine to talk to patients and our patients are accustomed to. These engineers are talking a different discourse to us. There's huge communication challenges, and we need to reach everyone because everyone needs to know what it means that COVID spreads by airborne measures. So what did we come up with? A little bit of Macbeth and a little bit of breathe easy, the course. Advise him to a caution to hold what distance his wisdom can provide. As an aside, Shakespeare was born and lived through the Black Plague. So Breathe Easy is a course we put together to provide information that people can act on about the airborne spread of COVID, including building a do-it-yourself air filtration device. Part one is didactic. We have text, visuals, and activities, and incorporate health literacy skills like learning what the size of a micron is, how to read a bar chart, right? Hands-on is part two, where we teach people how to build a Corsi Rosenthal box. So if we have anything to do with it, like Henry VI, he shall not breathe infection in this air. We did two things. We're training our champions to teach the course in the community. The trainer side, at the red text bar at the top of the page, and on the blue side of our flip book, we created a flip book for people to train with. The blue side is the student or neighbor side, right? So we provide the training materials to be delivered as well as training in how to deliver the course. And these are just a couple of samples. And again, every one of these, please applaud Kay because she is the genius that comes up with them. This is how we're demonstrating droplet versus airborne. Just very clear pictures of how big aerosols are, what a micron is, giving people some context, explaining the core concepts of ventilation visually as well as with some words. And then again, aerosols versus droplets. So lots of visuals, lots of clarity, and a lot of attention to the words we're using. Another piece, and sorry to rush here, I just know we're almost out of time, participatory public art project called Remembering Forward. We asked participants to tell their stories of living through COVID. We ended up with murals in Radium Springs. We've got several murals going in Hatch and other communities in the north. We engaged an extremely talented, well-known regional artist to do the process. But with it, we're building something else. We're building emotional literacy for people to be able to process the experience, the grief, the despair, the uncertainty of what it's been to live through these times and continues to be. We also use this as an opportunity to model and educate about COVID-safe behaviors. We're also using music, writing songs. We've got 3 songs, And we're engaging with community members to make music. We developed the Salud y Vida con Amigos band that played at the unveiling of one of the murals. It was a lot of fun. So I won't play this whole thing because it's a little long, but I'll give you just a little taste of one of the songs that we've done to communicate some things. Oops. You know what? You can't hear that, can you? Let's try that again.
Salud y Vida con Amigos, because the key to being free is indeed of literacy. Salud y Vida con Amigos, because the key is with you and me. There are answers to all that you ask.
Oops. I'm sorry. I'm trying to turn it up.
Salud y Vida con Amigos, because the key to being free is indeed of literacy. Salud y Vida con Amigos, because the key is with you and me. There are answers to all that you ask, even when I should wear this darn mask, 'cause we really think you should, if you want a life that's good. Salud y Vida con Amigos, because the key to being free is indeed of literacy. Salud y Vida con Amigos, because the key is with you and me. Protect others and yourself, grandma, kids, and Santa's elf.
Santa's elf?
Wear a mask to show you care, because there's virus everywhere. Salud y Vida con.
Okay, I'll stop there. Just with a little note, but we created an earworm, I guess is what I'm going to say. So thank you so much. I know we are close to the top of the hour, and just any questions, and please feel free at any point to email me comments, and I will pause here.
How long is the Health Literacy 101 course? You know, you said there's 2 parts. Right.
The course itself, I'm expecting will probably take someone in the range of 3 to 4 hours to complete the whole course online. It will be an online course.
Great.
So we're almost done rating. And then we do a whole process of K-bopping me over the head and and making it more health literate. And
right. And then you should probably run it by a few folks and see how
right.
they react to it. You know,
we'll pilot it. So, and we are we will have CEUs available, and we could probably work with multiple different agencies to get CEUs for different professionals, because I think it will fulfill a lot of different groups, from social workers to clinicians to. So
great.
Yeah.
Excellent. Thanks.
Thank you.
Nice job today, Reneé.
Well, thank you. Thank you, everyone.
If there are no other questions, we'll go ahead and close out today's lecture. Dr. Despres, thank you very much for joining us today.
Thank you for having me and my whole team. Thanks, everyone.